have two cases. The first one is a new one. The second one, I realize I may have shown before, but it's still a good case, so I don't really mind. But this one just came across recently, and I don't even remember what the indication was. This was for fatigue, so who knows. Relatively normal looking here on the frontal. And then I'm going to pull up the lateral here in our second image. And the thing that caught my eye here on the lateral is this density here that seems to be projecting behind the trachea and sort of under the level of the aortic arch. So this sort of rounded structure here, which seemed a little bit abnormal to me. I wasn't entirely sure what it was, so recommended that the patient get further imaging. We had nothing prior on them, and as far as I could tell from their chart, they had no prior chest imaging available. So we did get a chest CT. Unfortunately, it was non-con, but still I think shows this pretty well. And what we see here as we come down below the aortic arch is this structure wrapping around here behind the trachea and then coming across to the left hilum. So this is the left pulmonary artery, which wraps all the way around the trachea. Instead of going to the left of the trachea, it goes to the right and then wraps behind. So it looks like a pulmonary sling morphology, which corresponds nicely, that area here corresponds nicely to that sort of rounded density that we saw here on the lateral of the chest x-ray. Just to compare, here's the CT of it, right? So there's our density right there.
Cool. Are there any airway anomalies?
Let's see. I don't remember the top of my head, but let's check.
Besides that narrowing?
Yeah, just a little narrowing there. The little whatever schmutz hanging out.
No funny branching or anything.
No.
Could you show us a sagittal of the trachea? Just make sure we don't have indentations from complete tracheal rings around behind.
Good question.
No, nice and smooth posteriorly.
Yeah. But yeah, you're right. There was some bronchiectasis in that left lower lobe as well. But yeah, trachea itself looked okay. Sort of focally posterior in the left lower lobe. So maybe from some old infection or something.
Very cool. On the lateral view, you can see this big blob that you first pointed out. It flows into the left pulmonary artery, going over the top of the bronchus there.
Down here.
Yeah.
Yeah, cool. And then the other case that I had, which is on kind of a similar theme, and again, I may have shown this one before, or Travis may have shown this one before, but this is actually a case that I had when I was a resident on call. And this was a patient who came into our trauma center for history of, I think it was being hit by a car of some sort at low speed. And so they oftentimes will first do sort of pan x-rays in these patients. This patient had no prior imaging of any sort, and this was their chest x-ray. So obviously, several abnormalities here. We can see that the trachea is deviated towards the left. There's this sort of band of tissue with this lucency that looks like a lung projecting over it and then off to the other side. It's hard to make out the right heart border, so that plus the trachea suggests that there's probably some volume loss over here in the left lung. We don't see the normal aortic knob over here on the left, but we do probably see a right-sided aortic arch over here. But realistically, since I was, I don't know, probably a second-year resident reading this chest x-ray, I was like, I have no idea what's going on. Please get a chest CT, particularly in the setting of trauma, which is what we did. And this is a pretty classic appearance, which I now recognize, of a patient who has, an absent left pulmonary artery. So unilateral absence of the pulmonary artery. And we see all of these big tortuous bronchial arteries coming off the aorta and going to the left lung, supplying that small left lung. We have sort of associated hypertrophy of the right lung, which is pooching over midline, and it's what's causing that weird appearance of this lucency here overlying the mediastinum. And then this sort of band of tissue is that mediastinal fat over here. but yeah, this was this was a congenital issue, congenital absence of the pulmonary artery. And as with the classic teaching, it is happening on the opposite side of the aorta, which this person also has a right-sided aortic arch.
And it looks as if there's systemic arterialization coming in across the pleura, particularly in the lower lobes there. You have those little vessels penetrating.
All of these little ones.
Yeah. You know, it's interesting. I've looked at a few of our cases of this, and usually the lung's usually small, but I've seen some that are normal otherwise, and I've seen some that have weird cysts in it or weird emphysema-like looking spaces. So I guess I don't know why that happens, but probably abnormal development. Yours has impressive systemic supply, though. I've not seen one that impressive before.
Agree. I feel like we have a few other cases of this floating around, but this is definitely the most impressive.
It actually causes almost reticulation in that left lower lobe. Caused by the vessels coming in there.
So yeah. Anyways, those were my two cases. Two different pulmonary anomalies.
Very cool. Thanks, Maya. All right,
yeah,
David, do you have any cases?
I do.
Share away.
See, do you have to invite me or something to share?
No, you just hit on the top of the Teams, there's a share button next to the leave button, dangerous place to put it. If you click that, you can pick what you want to share.
Okay. So there's leave in there.
Yeah, it's like in PACS where they have quit right next to dictate.
Yeah. So I'm going to share screen. Okay. Do you see a chest röntgenogram?
For sure.
Okay. So this is a follow-up to what was shown 3 weeks ago when you first resumed the conference. I'd shown a case of absent pulmonary veins on the right, and Howard Mann said that somebody had shown a previous case in this webinar, and that was me, it turns out. And so here's that previous case, and this case is very similar to the case that I showed 3 weeks ago. For one thing, there are a bunch of there's a reticulation down here, which turns out to be caused by vessels penetrating the lung and supplying some blood flow to this right lung, which is otherwise deprived. So there was, as in the previous case, there was this rightward mediastinal shift. The right lung is small. And let's proceed to CT in this case. The heart size is normal. Left lung looks pretty normal. And I hope this will bring up CT, I hope. Okay, here's CT in this case. And no, this is CT in the next case. So I might have to, let's see. I think I can bring this up anonymous. Okay, so this was another follow-up. I think it was there was a case of thymoma that was presented, and the person had a lot of air trapping. And so this reminded me of a case I had of thymoma with associated air trapping that was shown to be constrictive bronchiolitis. So here's that case of mediastinal mass that was first thought to be thymoma and then was changed to a follicular dendritic cell carcinoma. And this person had PAMS, which is that multi-system immunological abnormality that results in air trapping. So Jonathan Chung wrote a follow-up to the conference 3 weeks ago, where he pointed out that this air trapping in conjunction with thymoma is actually called PAMS, P-A-M-S, which is polysystem or polycystic immune dysfunction sort of thing that results in constrictive bronchiolitis. I can't remember what the acronym precisely stands for. And so our case was called thymoma at first, then that was changed to a follicular dendritic cell carcinoma in the lung, in the mediastinum. And this did have PAMS, and we actually called it PAMS at that point. So Jonathan pointed out that this syndrome is called PAMS, and we had PAMS as well. Now, I'm not sure that we have very convincing evidence of the air trapping. It was visible on some of the CT scans, but we didn't do a lot of expiratory imaging in this case. So this mediastinal mass first called thymoma, changed to follicular dendritic cell sarcoma of the thymus, had this autoimmune condition that resulted in air trapping. And let's see, this is expiration here. So I think I will be able to show you the air trapping here with this. So along with air trapping, which involves the small airways, there's often central bronchial wall thickening and bronchiectasis that usually develops afterwards. And I'm sorry I don't have more convincing imaging, but this case from several years ago, which I think was shown in an earlier conference, had the same syndrome that was presented 3 weeks ago. It was Seth who presented, I think, this case of PAMS with thymoma. So I wanted to bring those two cases up from the past. And then this person has this upper mediastinal abnormality, also has a lot of fullness here in the neck tissue. And on CT, you can see that there is a very extensive, there's a mediastinal mass, and there's also this anterior chest wall big lesion as well. Okay, so here's our mediastinal mass. It's on both sides of the mediastinum. We have this abnormality then in the anterior chest wall. And then if we go up into the neck, we can see that this abnormality continues in the neck here. It's actually more impressive in the upper thorax and in the neck too. So we have this extensive abnormality. So what do you think?
Is it like a giant lymphatic malformation?
It is.
Yeah. Is
so
this like a?
Go
I
ahead.
forget what. Is it Gorham syndrome? I always forget the name of it.
Well, Gorham syndrome involves the main thing of Gorham's is you have to have bone involvement.
That's right.
And this person doesn't have any bone involvement except maybe secondarily. I mean, I think there was a little thing in here in the clavicle, but nothing very impressive. So it's not really much bone. So I think the better designation for these things is cystic hygroma, which is the term that was used, and when these things present in childhood. I think this woman is 39 years old. So this is an extensive lymphatic malformation here that had the terminology Gorham's, but I think better fits with cystic hygroma because there's very little bone involvement. So I've never seen anything like this at all.
No, that one's pretty impressive.
This is a grande on the Starbucks scale. Okay. Okay.
Very cool.
That's a great case.
And see, I'm sorry, I didn't really have a chance to get information that might have flashed by there.
I will.
Okay. So I wanted to show you this person here who has, at this point, has some mitral annulus calcification, okay? And it turns out that wasn't there a couple of years before. This person has a lot of other stuff going on too. So at this point, you can see that there's a destructive lesion here of the distal clavicle on this side. And there seems to be some calcification or heterotopic bone adjacent to it. And there's an earlier lesion actually going on the other side here. Here's a rib lesion down here. This person has chronic renal failure. Okay, and I showed you the abdominal CT that showed some mitral annulus calcification, which you can see faintly down here. So the years were not kind, and I may have to go back to the index here to proceed to the next. Let me see if I can bring up
clavicle surgical, or is that it looks like it's
this is not surgical.
So that's an erosion.
Yeah, or something.
Yeah, because there's some weird matrix around it.
This process has really accelerated. This is only a couple of years after that, and now you can see all of this heterotopic ossification here. So this is, or calcinosis here. So this is tumoral calcinosis in the setting of chronic renal failure. This is really florid degree clavicular destruction. Maybe there was a brown tumor that led to that. We now have a lot more destruction on the right side as well, and all this soft tissue calcification. Here's stuff farther down along the shoulder and everything like that. And notice that the mitral annulus calcification has increased quite a bit.
Mm-hmm.
And then there was a brain CT that suggested there was embolization of a piece of this mitral annulus calcification to the brain.
Wow.
So there was a calcification in the brain that was attributed to embolization from this mitral annulus calcification, which accelerated quite a bit over these years. So I'd never been aware of mitral annulus calcification being part of this soft tissue calcification process promoted by chronic renal failure. But there you go. So even, with probable embolization of mitral annulus calcification.
Impressive.
Okay. Now I think I have another case here, but we've had a lot of bulkiness from the display program today. So here's a person with a mediastinal mass and a history of AML. Okay. And that was then, and here is a few months later, you can see that mediastinal mass is probably bigger. There's now a lot of pleural effusion here on the left, some pleural effusion on the right. And let's scan through this mediastinal mass. So here it is, big thing like this. There was a PET scan, which I can't anonymize easily, and it showed uptake in the rim of this thing, but also uptake in axillary lymph nodes and several pleural locations here on the left. This particular CT scan is earlier than that last imaging, which had all the big left pleural effusion, but there was uptake in pleural nodules around here and pleural nodules over the left apex on the PET. So this was biopsied and returned the diagnosis of, well, what do you think?
Myeloid sarcoma.
Myeloid sarcoma. So we used to call this chloroma, and then they called it granulocytic sarcoma, and now they call it myeloid sarcoma. And I think the reason for changing it from granulocytic to myeloid is more general. It would include granulocytes, but also monocytes. And most of the people who have what we used to call chloromas have these masses that are sort of lymphoma-like masses, but from the myeloid series, have a predominantly monocytic component to their AML. So you used to talk about myelomonocytic leukemia. If there was that monocytic component, then you were more likely to have these tumors associated with this, not just a liquid malignancy floating in the bloodstream, but actual masses like this that sort of resemble lymphoma all around. So it makes sense to call this myelocytic sarcoma rather than granulocytic, because it might, rather than granulocytes, it might be monocyte or the monocyte component that's involved in forming these masses. So the current terminology is, as you said, myeloid sarcoma. So this is kind of the myeloid equivalent of lymphoma, which is the lymphocytic cell line. This is the myeloid cell line that's forming masses in addition to the leukemic component. So we're aware of ALL and lymphoma from the lymphocytic side. Now we have ALL. Now we have AML and myelocytic sarcomas as the equivalent on the other side. So
Very
I'm not
cool.
sure that I have any other. I do have this better CT, I think, that I can show you. Let's do this one. This will show you the more extensive. No, this is the more extensive. I'm sorry again. I'm having a lot of trouble with this, getting this display. This is the acceleration of that of the mitral annulus calcification in that previous case with all of the tumoral calcinosis. So that this has really progressed quite a bit, and it was this stuff that was embolic at this stage, embolic to the brain, probably. Now, have you? I've heard before of embolization coming from the mitral annulus calcifications. So I think there was a patient here long ago that had leg ischemia because of embolization of a chunk of the calcification of the mitral annulus. to the femoral artery. But this case evidently resulted in that going to the brain.
It's impressive. I don't think I've seen a case. I'm sure. I mean, it makes sense. It could happen, I guess.
Yeah.
But usually it doesn't because it's such a such a common finding.
Got it.
All right.
Okay, the other thing we had, Jeff, that I didn't show you this time because there's still some doubt about it, is a case of a abdominal mass. Got a needle biopsy, and they recovered blastomyces from it. So this was a paraduodenal abdominal mass. It looked like a necrotic node or something like that. And it had blastoma in it. Have you ever heard of such a thing?
Well, I mean, I've seen it in the prostate. It can disseminate. So, but it almost always enters through the lungs. So at some point it had to be in the lungs, but
Yeah.
um,
Nothing visible in the lung. But if there's follow-up on that case, I'll show it
yeah.
eventually.
I mean,
Okay.
if you actually recover the yeast, it has a very particular look to it. So if that's what they think it is, it probably is. Interesting. All right. Okay, I have two cases this week. First one's kind of a cool case, and I won't tell the diagnosis right away, but this is a youngish person who came in with chest pain. You can see there's a funny shape to the chest. There's kind of a pectus carinatum. There's a scoliosis. The aortic root is dilated, and they were looking for an acute aortic syndrome, but instead, you see the cause of chest pain is this pneumothorax. And the reason there's a pneumothorax is these little tiny blebs of the apices here. So this is a patient you can guess with Marfan syndrome, who's got multiple of the findings, but one of the things they can get is they can get emphysema or these weird cysts in their lungs, probably the same mechanism of sort of abnormal collagen or whatever, and then they, of course, can rupture. Probably could have gone a radiograph rather than a CT, but with that history of Marfan's, they're always worried about a dissection or something like that. So, but just remember the differential for included Marfan's is spontaneous pneumothorax from these bullae or blebs or whatever you want to call them. But it's pretty because you can actually see them right on top there.
Nice.
And yeah, and then this is a fun case. I don't think the diagnosis is in question for people, but especially if you're new to this or you're less experienced, this is a good pitfall case. So if you look at this patient, they're short of breath. And so we did a CT scan, outpatient. And initial glance, you might say, well, there's some ground glass opacity, which I guess technically there is, but you have to look carefully. And one of the things I always harp on my residents is when they're taking cases is they scroll too quickly and they miss subtle things. And if you start looking at this ground glass, you realize it's actually tiny little nodules. You see them along the fissures, right? The fissures are thickened there, and there's kind of an anterior posterior gradient, and there's clearly an upper zone predominance. There's definitely some down low. You can see a few out here. Probably the best thing to do is to make a MIP, a nice juicy MIP. And if you scroll, you can actually see these are all nodules. And then, of course, looking at the mediastinum makes this a lot easier. There's some mildly enlarged lymph nodes, symmetric, which of course you can get with any lung disease, but this degree of hilar lymphadenopathy is little, and these are pretty chunky nodes. So any thoughts?
Good look for sarcoid.
It's sarcoid, yeah.
I
You can
love
see
it.
right here, yeah.
It's
This is the
beautiful.
one, and in the literature, there's description, and even some of the books, it describes ground glass opacity as a finding of sarcoid. And I suspect, there are probably a few cases I've seen with some ground glass opacity that's real, but I suspect a lot of those are older cases of thicker slices. If we were to thicken this up here, let's say go to 5 millimeters all of a sudden, like they used to do back in the days, and sadly still occasionally do, those nodules may not look so nodular, and you can imagine this gets called ground glass opacity. So this is one that is a good case I show my trainees when they're a little bit more advanced to see if they can tease out the nodules. And it's hard to pick up the perilymphatic distribution, but really what you can see is along the fissure, they're clustering out there, and then the lymph nodes kind of give you a little bit of a boost in confidence in that. And it's not HP because, of course, HP nodules should be fairly exquisitely central lobular, and they're usually more extensive than this. They don't have quite the sparing that you see in the base down here. So a case of sarcoidosis with tiny, tiny ground glass nodules that look a lot like ground glass opacity. So that is all I have.